and a member of the scientific board of this event, and a friend of mine, actually, Dr. Mohammed Al-Gindi. Dr. Gindi, he has been graduated from the Faculty of Medicine at Shams University in Egypt, where he completed his postgrad training in anesthesia and intensive care medicine with his PhD degree from the Shams University. He's a director for internal and external fellowship programs in surgical critical care department at Shams University and board member for the Egyptian Society of the Intensive Care and Trauma Medicine. Dr. Muhammad is actually assistant professor currently and the deputy of the director of Ain Shams Surgical Critical Care Department, and he's having a great experience currently in managing COVID-19 patients across Egypt. Dr. Muhammad will continue, will talk about respiratory management of hypoxic COVID-19 patients.
Thank you very much. I hope everybody is still awake because it's a long webinar and everybody is getting excited by time. I'm very grateful for the previous speakers and very nice illustration by our dear colleagues. My talk today will be about the acute hypoxemic respiratory failure in COVID-19 cases or COVID-19 patients, with all its remarkable debates about the management. Our objectives will include pathophysiology by different phenotypes and clinical scenarios. Maybe we should pass by the ventilatory strategies used in different situations. And lastly, we will arrange for the proposed algorithm for management of these type of cases. Definitely, we have a lot of theories about, we do have a lot of theories about how come that the acute hypoxemic respiratory failure by COVID-19 progress very remarkably to ARDS. The first theory is proposed by the Surviving Sepsis Campaign, and they endorsed it in the guidelines last month, I think. And they managed to manage the COVID-19 pneumonia-induced ARDS, typically like non-COVID ARDS cases, in my opinion. Just to remind that they included some extra tips and tricks, including the PPEs and the new muscular blockade, and some modifications related to the pandemic. We will discuss the guidelines later on our presentation, but the big issue was Gattinoni and his group. I was thinking that maybe some people are hearing about it, but actually in the last couple of days, everybody around the continent is speaking about the Gattinoni theory. It depends mainly on the two phenotypes, as all of our colleagues have just mentioned, the type L and the type H. The type L is a low elastance model, which will stand for an early phase of the disease involving the lung parenchyma, sustaining a normal lung compliance, while the type H is standing for the high elastance or the later phase of the disease with the low compliance of the lung. We will discuss it a little bit more detailed after a couple of minutes. Whilst the novel theory stands for the pulmonary microthrombi, which is very, very comprehensive and very well accepted theory with the endothelial dysfunction. And lastly, in the previous couple of days, we will hit the hemoglobinopathy theory, which is standing apart from the other theories we are following. So to start with Gattinoni have just published two editorials and letter to the editor. One titled "The COVID-19 doesn't lead to a typical ARDS" in the American Journal of Respiratory and Critical Care Medicine, and the other is COVID-19 pneumonia, a different respiratory treatment for different phenotypes. This was published in Intensive Care Medicine. The main concept with the Gattinoni group that they always discussed that there is a dissociation between the patient relatively well-preserved lung mechanics and the severity of hypoxemia. And this well endorsed by many of our colleagues as silent hypoxemia. To start with the first phenotype in a little bit details, it's called the type L, or the early phase of the pneumonia. On the left side of the screen, you can see two CT scans I think all of our dear colleagues have mentioned a part about the CAT scan in this type of patients. I'm very fond of doing CAT scans for these type of cases, especially in early phases. Like all intensivists who are a little bit wondering what is happening for your patient. You can imagine that there is a subpleural GGO or ground glass opacity, which is scattered either in the subpleural space, maybe in the middle loop, posterior segment of the lung. But overall, you don't have a much more consolidation or collapse or lung water increase in the extravascular lung water. The other law is a low VP ratio, or the low ventilation perfusion. And in their theory, they are proposing that the perfusion is increased by vasoplegia and loss of the hypoxic pulmonary vasoconstriction, reflex lost. So you're having a perfused area of the lung, which is not over-perfused, which is not well ventilated. Low lung weight and low recruitability demand. Low lung weight because the lung is very well aerated, and low recruitability because the lung is full of air. You don't have to aerate a full aerated lung. So you have a good question here. If you are using PEEP, why are you using PEEP in the early phase? To get things more clear, pneumonia or pathology of the L phase is simply pneumonia, very mild pneumonia, with a local subpleural edema, vasoplegia, increased vascular permeability. All of these components with a very strong alarm of thrombosis, which is another theory, will lead to severe hypoxemia. But the patient is having a good lung compliance, aerated lung. So if all these pathologies lead to severe hypoxemia, the patient, this hypoxemia will stimulate the upper respiratory centers to increase the mean ventilation to overcome this hypoxia by increasing the tidal volume. You don't need to increase the rate because the lung compliance is good. You just need to increase the tidal volume. In the theory of Gattinoni and his colleagues, it may reach 2 to 3 times the actual mean volume or the actual tidal volume of the case of the patient. It may reach 15 to 20 milliliter per kg. This is not actually accompanied by any increase in the PaCO2 or the CO2 partial pressure. All of this will result in the early phase a very high negative interthoracic pressure with a good compliance. So the patient is not dyspneic anymore. He is compensating in the early phase. So either it ends by recovery or deterioration. A very simple X-ray, which we have discussed many times today, it seems to be just some sort of peripheral opacification, but no consolidation or collapse or focal lesion. Again, the CT of the same case. It seems just subpleural ground glass opacities. What about what's happened later? What will happen later that you are faced by increasing the inflammation, increasing the intrathoracic negativity by time, 3 to 4 days in most of the studies, ending by capillary mobility, severe increase in capillary mobility and increase in the intrathoracic negative pressure. It will end by what is called patient-inflicted or patient self-inflicted lung injury. This will be increasing extravascular lung water, lung collapse, and much more pressure inside the lung. And this is the CT in the later phase. It is another different pathology totally. This is the whole theory, that you are passing from minimal affection to marked affection, and it will last by decreasing the aerated lung volume on the contrary of the other side, and this ends by dyspnea and respiratory failure. To cut things more clear, this is on the left side, the chest X-ray and the CAT scan we have just mentioned in the early phase, while on the right side, you got the opacifications getting more clear and more apparent, and maybe the CT down here, a lot of consolidation as we just mentioned. There's a big difference between both cases. So phenotyping again, if you have a type H is the high end side or the high side. This is the CAT scan of the type H or the later phase. Later phase have a high elastance, low compliance means. high chanting, right to left chant. Why? Because a lot of blood is chanted from the right side of the heart to the left side of the heart, but the lung is not there. So you do have a big shunt fraction now in this late phase. High lung weight by quantitative CT finding, it may reach up to 1.5 kilograms or more. And lastly, in this stage, you need to recruit the lung because it's a lot of water, a lot of collapse, a lot of maybe in some instances consolidation. So what is the ventilatory strategy proposed by Gattinone and his team? Start by non-invasive, start by escalating the oxygen therapy. High flow nasal oxygen will do the job, maybe. CPAP versus non-invasive, as our dear colleagues have just mentioned with Walid and Dr. Sameh and Dr. Adel. Targets may be, as usual, SpO2 be above 92%. Acceptable work of breathing is a very good point, because if you have a lot of negative intrathoracic pressure, you will remarkably have the patient by time getting water inside the lung. And in this point, the patient will do much more effort to get his better breathing or better oxygen intake. So if water comes inside, the work of breathing is increased. You can inspect it clinically by the movement or the activity of the accessory muscles, by swinging in the CVP between the inspiration and expiration, or by changes in the esophageal pressures, if you can put it. I wonder how in a patient who is living on oxygen nasal plunge or high flow nasal, it's a little bit difficult, except if you are putting a non-invasive outside the chest. So be aware of delayed intubation. This patient may be in a couple of hours passing from elective intubation to an emergency intubation because of the rapid deterioration. And this should be announced and should be considered an emergency situation. So if we put, after you put your tube, all this was a non-invasive strategy. If you put your tube inside the lung or endotracheal, you have two patients, one in the early phase and one on the late phase, or the one in the type L and the other in the type H. Tidal volume, most probably the early one, the one with the preserved non-compliance, with the low elastance, high compliance, can take more than 8 ml per kg because there is no risk of strain injury by increasing the volume. You can use the regular lung protective strategy on the other side of the patient, type H, by using low tidal volume, plateau pressure below 30 and driving pressure below 15 centimeter water. If sustained hypoxemia, I guess that prone position in both type of patients is making sense, especially if the type L or the low elastance high compliance is still hypoxic. So he's having another problem. Maybe the ventilation perfusion mismatch is corrected by getting the lung upside down. And proning is a classical maneuver in case of type H or ARDS cases in the late phase. What about PEEP? PEEP is low in the type L, and we have just mentioned, because you don't have a collapsed lung to inflate. And if you have the lung inflated and you put the PEEP inside it, it will be transmitted from the intra-alveolar compartment to the intrathoracic compartment. So you get a negative impact on the venous return and a low cardiac output. What about recruitability in the type L? You don't have any chance to recruit a well-recruited lung. While in type H, you can use a high PEEP and recruitment maneuver to be optimized. ECMO is the standard rescue therapy all around the world if you have the resources and you have got it. But this is the policy of Gattinone class. What other ventilatory protocols do we have on the ground? The utmost important protocol is the Surviving Sepsis Campaign protocol, which was published in March, and it's very important as it is our frame in management all over the world. It simply goes by sense. Start by if you have a COVID-19 hypoxic case, if there is an indication for intubation, please go for it, but be aware of exposure, be aware of doing it by the expert airway managing physician, be aware of the PPE, do a 995 FPP2 at least, or FPP3, as Dr. Ahmed told us in the first session. minimal staff in the room, minimal number of staff in the room, and consider the most important thing, the videoscopic laryngoscopy to provide a contactless field. While if the patient can tolerate non-invasive, so you go for high flow nasal cannula, you go for non-invasive for a very short time, and you can do this as long as you can target SpO2 above 92. You can monitor the patient very closely, which is very unlikely to do in this pandemic. Appropriate infection control, as we have just mentioned, is very important. They define the ARDS as usual to mild, moderate, and severe. I don't think it's a big challenge here. That they are using a general plan as usual, as much as possible. The mild form can do a tidal volume of 4 to 8 ml per kg, plateau of pressure of less than 30. But in moderate to severe, you consider a higher PEEP. In mild or severe, you can do for rescue therapy. But in mild form, you use tidal volume of 4 to 8, plateau of less than 30. Investigations of bacterial, target of SpO2 of 92 to 96%. Conservative fluid therapy, which you should revise yourself a little bit about this, because conservative fluid strategy should be revised very promptly nowadays, because we have a lot of thrombotic events from this conservative fluid strategy. Empirical antibiotics is fine. Using steroids is controversial, even in the Surviving Sepsis campaign. In the moderate to severe ARDS, you can use a high PEEP. You can use a new muscular blockade. You can use a traditional recruitment maneuver and avoid stepwise recruitment to avoid lung injury and to avoid the cytokine storm. Maybe proning, it's very good option. I think the common sense in every study till date is using a prone position whenever it's feasible. As Dr. E just mentioned, maybe it's better to use it before ventilation. Things are still controllable and patient may be cooperative enough. New muscular blockade again. Don't use a staircase or a stepwise approach recruitment maneuver. And rescue therapies will start by antivirus, chloroquine, new muscular blockade infusion, and lastly, ECMO as a whole. My point of view here that we can manage things a little bit differently. If you look in this pyramid, you can revise in the low compartment. You can use non-invasive, which is the non-invasive strategy before getting to the invasive strategy. It may be a mild or moderate degree of hypoxemia because it's the L type of phenotype of Gattinoni. You can consider nitric oxide, I think. You can consider prostacycline. You can consider high flow nasal or non-invasive with proning. If you have a normal compliance, this would be perfect solution. And I have many of my colleagues in Britain and Canada using them nowadays. CPAP and non-invasive, high flow nasal oxygen as standard, and the least is the low flow. If you are going to invasive with a mild to moderate hypoxemia by invasive maneuver with a PF ratio of 100 to 200, you should think about recruitment, new muscular blockade, proning, and lung protective strategy. But proning will be first if you have a normal compliance. So if you have normal compliance, I think you should concentrate on using a high flow nasal or non-invasive with proning if you are non-invasively. But you can go for intubation if the hypoxemia is getting more and more and the patient is dyspneic, a lot of work of breathing. You can intubate him and put him in proning if you are still having a good lung compliance before doing the blockade and recruitment and lung protective strategies as the first line. The last and not the least is the ECMO, the man of every time and place as in refractory hypoxemia rescue therapy. That's my view. I'll finish by a couple of slides revising the novel theories regarding the novel theories about vascular thrombosis and endotheliopathy, and lastly, the hemoglobinopathy. This is a very complex slide, but it is a courtesy of Farid Jalali. He's a gastroenterologist in California. He is discussing how come that the COVID-19 may act like the AC inhibitors and act like the dengue fever in increasing the interleukin-6, the plasminogen activator inhibitor 1, and this will be a prothrombotic complication. If there is a sudden thrombotic surge, it will be characterized, as we all see, by increasing in D-dimer, increasing in ferritin, CRP, and maybe interleukins start in a very high phase of cytokine storm, and there is a correlation between the cytokine storm and the thrombotic events to some degree. But if you are following the sepsis-induced coagulopathy score, which includes all the coagulation profile, and you get a count more than 3 to 4, you are just a little bit in trouble with your patient, and you should, to my mind, you should think a lot about starting anticoagulation, plus or minus antithrombotics or antiplatelets if there is a microvascular problem. You have a microvascular or macrovascular pathology. The microvascular usually reported with an MRIs, cardiac microvascular thrombosis reported renal, as Dr. Ahmed, Dr. Hisham have mentioned, with a very high risk. Macrovascular thrombosis, pulmonary embolism, and cerebrovascular accidents are actually reported in many cases. So on the day of the 10th to 14th day, sudden death occurred all over the world in many patients from the 10th day to the 25th day. And it was a sudden death. Actually, a lot of debate about a massive acute pulmonary embolism, massive acute MI, massive cardiomyopathy, and arrhythmia and AKI, or equivalent life-threatening problems. So you can think a lot about treating these patients. Novel theory, or the endothelial injury, endothelial dysfunction, may be the invitant or maybe the provocative material for these thrombotic events, and on the same time for provoking the release of interleukins and inflammatory mediators, ending by the cytokine storm phenomena. Clinically evident by the clinical evidence of endotheliopathy and thrombosis is sudden or silent, severe hypoxemia, normal with a normal lung compliance and normal airway. You have severe hypoxemia, which is of unknown parenchymatous problem. Radiologically, early you got very patchy infiltrates of ground glass opacity. Your labs, if you count the substance-induced coagulopathy, there's a debatable figures about D-dimer, fibrinogen, and coagulation profile. Echo, you should follow the echo for diagnosing an acute LVCV systolic dysfunction unexplained by any previous history, plus or minus LV dysfunction in case of massive pulmonary embolism. Postmortem autopsies, I got a couple of slides about this, but I didn't put them in my presentation till they are getting more evidence-based, because there is a lot of Chinese postmortem and nowadays Italian autopsies showing a disseminated thrombosis in the lung, heart, kidney, and brain with a marked endothelial damage. Lastly, I can think a little bit about the novel treatment approach. This is a study in the United States. I think I'm running out of time. A study of the United States just published yesterday, maybe, about novel treatment of using a plasma exchange for refinement cases. All patients were on 2 vasopressors, all patients on mechanical ventilation, and actually this group are coming up with a very good results in refinement cases by using plasma exchange. This is the pathophysiology. For the sake of time, you can come back to it. The infection is coming by cytokine inflammation, endothelial activation, pathological coagulation, and all of them is coming with the same result. I'm very thankful for you, but this is a worthy thinking slide to think about the hemoglobinopathy theory, which I will end by this abstract from a Chinese paper about the role of the ORF or the genetic material function, which can attack the hemoglobin of the human RBCs. The lung cells, when attacking the hemoglobin, it can affect the 1-beta chain of the hemoglobin, dissociating the iron to get rid of the porphyrin. And in this theory, if the virus can invade the hemoglobin and get the porphyrin out. So you had a big trouble. This attack will result in a severe lung injury, inability of the hemoglobin to carry oxygen and carbon dioxide, and it will be a very much good explanation for having silent hypoxemia also. So chloroquine and favipiravir are used in these episodes on pandemics in China. By this theory, they have explained that the chloroquine can stop the effect of the virus invading the hemoglobin or getting rid of the heme portion to stop the ion, the oxygen carrying capacity and the ability to get rid of CO2. And by this, I am thanking very much our dear colleagues, and thank you, Dr. Ahmed.
Thank you so much, Dr. Muhammad. Actually, your topic is very hot. You started from basic until the advanced and the up to date, I think, until today morning. For sake of time, I'd like actually to present our next guest speaker, a diamond of the scientific world, Dr. Walid Al-Habashi. Dr. Walid actually, he finished his master degree as well as his PhD degree in anesthesiology and ICU at Tanta University Hospital. He's of course my friend, and we are from the same university. But Dr. Walid actually, he earned a lot of certificates: European Diploma of Anaesthesia and Intensive Care Medicine, Arab Board of Anaesthesia and Intensive Care, Fellowship of the College of Anaesthesia and of Ireland, and National Board of Critical Care Echocardiography from USA just now. He is leading many critical care ultrasound and echocardiographic course worldwide, actually, the leader, and has his own YouTube. He's working now in a very, very busy center of COVID-19 crisis in Dublin. Dr. Walid will talk with us now about the rescue therapy of patients of COVID-19. He will talk about prone positioning. Welcome, Dr. Walid.
Thanks very much, Dr. Ahmed. Actually, I just want to declare one thing before I start. Dr. Ahmed was my teacher in residency, so I owe him a lot of what I learned from before. So my talk today will be one of the rescue therapies. We should have been starting with the primary therapies of COVID-19 and respiratory failure and support, but due to the technical issue with Dr. Gindi, I will take over, and I hope you to tolerate with me just for 15 to 17 minutes with this lecture. So I am talking about prone positioning, and Dr. Ian Conrick Martin is covering the other rescue therapy, which is ECMO. So Bismillah ar-Rahman ar-Rahim, my topic would be the proning in COVID-19 patient respiratory failure. I have no disclosures related to this conference or this lecture. I am covering the objectives of the evidence, which is definitely, I will try to take mainly the anecdotal evidence of proning in general ARDS patients, as there is no enough available data or evidence yet in the COVID proning. So next point I'll go to cover is it safe procedure and how safe it is, what is the indications or who is indicated for that, are there any contraindications for proning the patients, what do we need to prepare before we prone? So is proning for everyone, and is there any plan before doing that? Practical approach to proning. So I'm sharing one video. It's recorded actually in the Mater University Hospital like 10 or 15 days ago, just to make training for everybody with using simulation for proning. So I strongly recommend that for everyone going and preparing for their hospital to be a COVID center. Train your team, train your staff first. Be very practical, because once the crisis hits, you'll find no time for training. So evidence, what are the quality of evidence available now? There's a lot of randomized controlled trials consistently demonstrating that oxygenation is significantly improving when in ARDS patients when we prone them. Current evidence shows that early application of prolonged proning positioning may significantly increase mortality as well compared to conventional supine position, again in ARDS patients. Cochrane systematic review in 2015 showed that prone ventilation for 16 hours per day for 5 to 6 days has a dramatic effect on the mortality rates. Our current COVID evidence is mainly depending on the anecdotal experience of the critical care consultants or intensivists all over the world rather than solid evidence. So we have to take the word and try it in our centers and come out with more research to get more support. So safety concerns. Safety concerns, is any complications related to that one? Yes, there is a lot. There is pressure sores. Most cited injury is the pressure pressure sores. Ocular injuries, corneal abrasions, periorbital edema, IV line displacement, endotracheal tube displacement, cardiovascular instability after proning, brachial plexus injuries, so tend to keep every degree is less than 90 degrees in the angles of body. Staff injury, so you need to do proper staffing. So in shortage of staffing, I have a bit of question, is this really applicable? So again, crisis management and resources, we have to weigh the cost versus the benefits. So CRRT line flow problems, particularly with the femoral lines. So these complications are like in all literatures, but is that preventable? How can we prevent them? So the gold standard here is you see what you know. If you don't know what are the complications, you cannot avoid them. So read the complications and read the literature about complications in prone positioning, so you can expect this and plan to prevent it. You have to adopt a protocolized approach tailored to your unit facilities and equipment. So how many nurses you have, what are the equipments, what are the tools? It can be simple versus very complex or sophisticated approach for proning. Training of your staff using simulation-based real-life training in the units working with the COVID-19. So again, training before the crisis hits hard. Indications, moderate to severe ARDS, and here we're talking about PF ratio less than 150 with an FiO2 more than 60%. Early within the course of the disease, and we are talking about the first 48 hours, early proning rather than late. So before the ARDS changed into fibrosis, and it becomes more harder problem to solve. Best outcomes are achieved when tidal volume are 6 ml per kg predicted body weight. So again, we are still using the ARDS net protocol, the ARDS net protocol for ventilation. Either we are proned or not proned. I mean, you don't have to reduce the tidal volume while you are proning. Is there any contraindications for proning? Yes, unstable spinal injuries, less than 24 hours of cardiac surgery. And we face a lot of that nowadays because every patient in hospital, like cardiac surgery, he was in hospital and then the pandemic came. So everyone is at risk regularly as anybody in the street. So less than 24 hours of post-cardiac surgery is not recommended to prone as per the literature. Central cannulation like ECMO and ventricular assist device is a bit very questionable. And in our center, the patients who were on ECMO, we actually didn't have to put them on proning, but I will leave that discussion or that part of discussion to Ian in the lecture after me. Raised intracranial pressure, and how raised? We are talking about anything above 30 millimeters of mercury or cerebral perfusion pressures less than 60. What is relative contraindications? So multi-trauma patient with multiple fractures, bleeding, head injuries in general, seizures if it's uncontrollable, raised intraocular pressures, pregnancy, particularly in second or third trimesters, that can be tailored approach or modified approach. But again, you have in this crisis to prioritize your risks and benefits. So what are the equipment? Simple equipments, I think, may be available in every unit. So I'm recommending really strongly, if you have enough staffing, you go for proning. Shades, bed sheets, 3 to 5 pillows, depending on your policy and protocol in your center again. So some people use 3, some people or some centers use 4 pillows. ECG electrodes, absorbent bed, and airway trolley should be kept clean out of the room just in case if any intratracheal airway loss, and you can do like supination again and re-intubate the patient. So keep the airway trolley always ready because this is not uncommon. So pre-procedure, what you need to check or to prepare. It's a multidisciplinary team discussion should happen before proning because we need to know that is there any contraindication in this patient? We need to ensure adequate number of staffing. So this nurse or CNM needs to come in this discussion. Ensure that it is, again, no outstanding procedures. So this patient is not going to CT after 2 or 3 hours because all the procedure will be postponed after proning. So if there is any outstanding procedures that is really life-threatening, like sharing as life-saving, in this you have to consider before proning. Airway trolley again should be checked, available outside the room in a clean area with a nurse outside helping, as the clean nurse can push that if it's needed. Securely tape your intratracheal tube to maintain his airway. Suction the oropharynx and airway prior to procedure. Pre-oxygenate with 100% FiO2 all the time, like for 3 to 5 minutes. And in our center, we do it 5 minutes rather than 3. Ensure all lines are sutured and secured. Disconnect the arterial line and end-tidal CO2. This is all the lines that you should take care of. Discontinue all non-essential monitors and equipment from the patient. And again, be ready that your patient may be in the cardiovascular system compromised despite he was hemodynamically stable before proning. So make sure that your inotropes and pressors are ready to go and but not connected before proning. The neuro patient should receive adequate sedation and 1 shot of paralysis before you prone your patient. Skin and eye integrity. So please keep the eyes clean, lubricated, taped to prevent drying and ulceration. Nursing staff should document nursing skin integrity before proning and after proning. So this should be a part of the protocol in every ICU. Nasogastric tube feeds should be stopped, disconnected, and aspirate in nasogastric tube. And again, document the length of your nasogastric tube before you prone your patient. So if it is dislodged, you know if you can push it again, or you need to keep the patient without nasogastric tube till you get him into supine position again. All cables should be above the waist. If they are coming above the waist, keep them on the top, and if they are coming from below the waist, keep them towards down. So this is the lines and tubes. This is one photo with the anesthetist is taking care of the patient airway here. Sorry for that. And this is sometimes different protocols in different countries. In this picture is from UK, is explaining that they put the pillows, 3 pillows or 4 pillows on the patient before they put the second sheet here. So this is a protocol in United Kingdom, I believe. So or I've seen that before with some videos in the UK. But in Ireland, we do these pillows out of these 2 sheets wrapping the patient. Now I leave you with the video that is taped really in our hospital, and thanks for everyone shared to bring this action into life. This is showing how that simulation and training makes a lot. Leave you with the video. I'm sorry, there is a sound problem here. So let me correct that before we proceed.
This educational video demonstrates our method of proning in the Mater ICU. For the purposes of this video, we won't be wearing personal protective equipment. The Mater protocol for donning and doffing has been well covered in other videos. Proning is an evidence-based intervention for severe hypoxic respiratory failure and has a demonstrated mortality benefit. Our practice is to prone for 16 hours a day and to supinate the patient for 8 hours to allow for relief of pressure sores and routine care. The decision to prone will be made by a consultant intensivist. We will now talk you through the process of proning, the preparation, the turning prone of the patient, position changes in the prone position, and supination of the prone patient. In terms of personnel, an airway trained doctor, anaesthetist or intensivist should be at the head of the bed, and 4 to 6 staff members are required for turning, 2 to 3 on each side of the patient. In terms of equipment, 4 pillows should be in the room, a standard hospital sheet, and a head pillow for proning the patient is required. In order to prepare the patient for proning, ensure all essential care is complete. Pre-oxygenate the patient to an FiO2 of 100% on the ventilator. Administer a neuromuscular blocking agent. Stop the NG feed and aspirate the nasogastric tube. Lubricate and tape the patient's eyes. ensure availability of the head ring, remove the patient's gown, and remove the ECG dots from the anterior chest, repositioning them on the patient's back. Disconnect and cap the arterial line. Check connections, ensure the ET tube is secure, ensure all lines are free and of adequate length. The chest drain and the urinary catheter are conventionally directed towards the patient's feet, whereas all lines above the patient's waist are directed towards the head. The closed suction is disconnected prior to turning the patient prone. And as a final step, the end-tidal CO2 monitor is disconnected and capped. Now we're ready to turn the patient into the prone position. A sheet is placed over the patient. The undersheet is loosened and both sheets are lined up, ensuring all four corners meet. The head pillow is removed from the patient. Next, the staff burrito roll the sheet towards the patient. They roll the edges right in to meet the patient. The airway doctor gives the command to move the patient to the edge of the bed away from the ventilator. Next, the patient is turned into a lateral position facing the ventilator. Pillows are placed across the bed at the patient's chest and pelvis, ensuring that the abdomen is free. Again, the airway doctor gives the command to turn the patient into the prone position. Pressure areas are checked. The head ring is positioned and the patient's head is turned to face the ventilator. The airway doctor ensures that there is no pressure on the patient's eyes, nose, or chin. Monitors are reconnected. Enteral feeding is restarted. The patient's head is checked to ensure that the head is facing the ventilator with no pressure on the eyes, nose, or chin. The patient is placed in the swimmer's position. Conventionally, the first head turn is in the direction of the ventilator and with the right arm and the right leg flexed in the swimmer position. The pressure areas are checked. The patient is now correctly placed in the prone position. Next, we will demonstrate the correct turning of the head and of the limbs, which should be carried out every 4 hours in the prone position. For this procedure, 3 members of staff, including An airway trained doctor must be present. The right arm and leg are extended. 2 staff members lift the patient's shoulder while the airway doctor turns the patient's head in the opposite direction.
So this is how we do the proning for 16 hours, then change the head position every 4 hours, then back to supine for 8 hours, and starting from next day will be like proning again. So we usually prone in the day time. So once we finish 8 hours on supine, but by the end of the day, we do the proning. So the patient stays 16 hours with just a change of the head position during the night shifts to make it like suitable more for less staffing and night hours. So this is how we do proning in our hospital. As you see here, thanks to Dr. Mairead Hayes for the commentary. Thanks to Dr. Jennifer Hastings for helping out of this happen. This video happens and comes to life. And this is how we push the patient back to supine position.
The patient is pre-oxygenated to an FiO2 of 100%. Monitors are disconnected. ECG dots are removed from the patient's back. The arterial line is disconnected and capped. The end-tidal CO2 monitor is disconnected and capped. The nasogastric tube is aspirated and enteral feeding is suspended. A neuromuscular blocking agent is administered. A sheet is placed over the patient, ensuring that the 4 corners match with the undersheet. And staff roll the edges of the sheet close to the patient. Connections are checked, ensuring all ventilator connections are secure and all lines are free. The airway doctor gives the command to move the patient to the edge of the bed towards the ventilator. Next, the patient is turned 90 degrees towards the ventilator. Pillows positioned at the patient's chest and pelvis are removed. And again, the airway doctor gives the command to turn the patient into the supine position. It may be necessary at this point to reposition the patient into a more central position in the bed. Lines and ventilator connections are checked and monitors are reattached. The arterial line, the end-tidal CO2 monitor, the nasogastric tube connection, and once the patient is stable, the enteral feed is reconnected. Closed suction is reconnected and staff check the patient's pressure areas. The patient will remain in the supine position for 8 hours. This completes the process of proning, supination, and change in position of the prone patient. A consultant intensivist will make the decision to move the patient back into the prone position if further proning is clinically indicated.
So thanks again for everyone shared in this video to happen. Dr. Brian Marsh, Dr. Jennifer Hastings, and Dr. Mairead Hayes, and everyone behind the scene from nurses and doctor colleagues. So just few special circumstances you need to take care of when you are doing a prone positioning, and this is maybe the slide before last. So prone positioning on ECMO, I don't have myself any clinical expertise in that regard, and I will leave that to Dr. Martin if he has some input in that regard. But in cardiac arrest, during prone positioning, now the European Society of Anaesthesiologists is recommending to do the compressions in the prone position rather than putting him in supine back, but it's not unlogic to give him a DC shock. So if the patient is cardiovascularly unstable, make sure you get. I'm back. Sorry, there was a bit of connection problem with me. So this is the last slide to share. So this is the efficacy and safety of early prone positioning combined with the high flow nasal cannula or non-invasive ventilation. So now we are thinking to prone early better than late, even before invasive ventilation. This is a study that's published in a multi-center, but in 2018, 2019, it was not related to COVID, but we are taking currently that on board, and we are thinking, okay, if proning is helping oxygenation, and it's helping as early as we can, so why we don't start it as early as possible, even before? So again, recruitment of the patient is a clinical concern. Whom to be proned? What's the nursing level of care in the ward? Will it be feasible? So the easiest thing to do is ask the patient if he's willing to do the proning. Okay, well and good. If he's young enough, no comorbidities, or he's not in a nursing home, nursing level will be sufficient for that. So why not? It may help to prevent intubation and will help to decrease the burden on the ICU later on. That's it. These are parts of the reference I used, and please, and thanks so much. Please stay safe.
Thank you, Dr. Eid, so much actually for very nice presentations and for real value for your institutions. I will Dr. Ian Martin. Dr. Ian Martin, he's trained in critical care medicine and cardiothoracic anesthesia at Mater Misericordiae University Hospital. I hope I pronounced it rightly, in Dublin. Also, he's trained in ECMO, cardiothoracic anesthesia, and the ICU at Royal Brompton Hospital in London and Queen Elizabeth Hospital in Birmingham, UK. Currently, he's working as a consultant in intensive care medicine at Mater Misericordiae University in Dublin, Ireland. His subspecialty for thoracic using rescue therapy for ARDS patient, as well as ECMO, as well as human factors in critical care medicine. I'd like to welcome Dr. Martin. He will talk about his experience of ECMO as a rescue therapy for COVID-19 patients. Welcome, Dr. Martin.
Thank you, colleagues, and good evening. I hope everyone can hear me okay.
Yes, it's fine.
I've been asked to speak on ECMO in the COVID era, and I'm very thankful for the opportunity to present, and thank you to Dr. Waleed particularly, but to all colleagues. I think events like this and collaborative events like this are the way forward, particularly in a disease like this. We in Ireland certainly have been the beneficiaries of webinars and events like this in recent weeks, and I think sharing the knowledge and sharing experience in what is relatively an evidence-free zone is really helpful, so thank you to start. Just in terms of the contents of the talk, a little bit of background to begin. I'm going to rather flick through the nuts and bolts of ECMO rather quickly, if that's okay, just in terms of the components and configuration of the ECMO machine, because it really isn't the point of the talk at all. Some indications or contraindications for the use of ECMO, some unit-specific experience for COVID and ECMO, and then some general evidence or guidelines on the use of ECMO in COVID-19 patients. As you're all aware, COVID-19 was declared a global pandemic on the 11th of March 2020. As of about an hour ago, there were just over 1.7 million cases of COVID-19 diagnosed globally, with over 100,000 deaths. Just by way of background, the unit in which I work in the Mater Hospital, it's a 36-bed critical care unit involving level 2 and level 3 care. We are the National Adult ECMO Referral Unit for Ireland. And currently, just again for information, we're at our level 2 surge stage. So we have maximized our intensive care, and we have breached into the HDU where we're applying level 3 care. What is ECMO? Some of you will know ECMO as extracorporeal life support. It essentially is the same process, and I'm going to use the two terms interchangeably throughout this talk. ECMO provides a short-term form of organ support, be it lung and or heart support, for patients who have failed conventional optimal supports. In terms of the ECMO components, very simply, there is a drainage cannula which drains venous blood from the patient to the ECMO machine, a return cannula delivering blood back to from the ECMO machine to the patient. A pump, centrifugal in nature, is required to generate this flow, a gas exchange device to scrub out some CO2 and to oxygenate the blood. In very, very simple terms, vena-venous ECMO, blood taken from the venous side of the circulation, delivered to the venous side of the circulation, is used for lung failure, and veno-arterial or VA ECMO, the blood taken from the venous side of the circulation and delivered to the arterial side of the circulation for a combination of lung and heart failure. As with all extracorporeal circuits, anticoagulation is required in order to prevent clotting of that extracorporeal circuit. Just in the interest of time, I'm going to very quickly just fly through this. The impeller type pumps and pump heads that we use in recent years are really, really impressive pieces of kit. They tend nowadays to be magnetically levitated, so there isn't a mechanical hemolysis or any mechanical damage to the blood itself. And as a consequence of this, these technologies can last for many, many weeks. Everyone tends to focus a little bit on the ECMO cannulae themselves, and sure, they are important. However, far more important is the team approach to ECMO, and I'll come to that in a while. But generally speaking, we use percutaneous cannulation in order to insert our cannulae into our patients. Just to draw your attention to two particular types of cannulae.
Dr. Martin, you can check your mic.
It's fine, Dr. Ahmed, I hear clearly here.
You still okay?
Yeah, here it's okay for me also.
Okay, I'm just going to carry on then. So just to mention two cannulas, specifically the multi-stage drainage
cannula. Your
cannula.
voice is not clear. Can you check your mic, please?
Is this okay? Is this a little bit better for everyone?
Yeah, it's fine. We can hear you clearly, Dr. Martin.
Okay, I'm going to carry on. So this multi-stage cannula is very, very nice in terms of generating some drainage flow from the patient. You can see the holes along the side of the cannula, so you don't just get drainage from the end of the cannula itself. You actually get some flow from along the side, so you can generate 4 or 5, even 6 liters of flow, so almost the entire cardiac output if you wish.
Still.
I think, Dr. Ahmed, it's your speakers. The mic is from my side, and from candidate side is fine. So I think it's your speakers. Check your speakers.
Still no voice.
Yes, it's working excellent, Dr. Ahmed. It's working excellent, just excellent.
So secondly, the bicaval dual lumen cannula, also known as the Avalon cannula, is quite a nice type of cannula for venous ECMO. You can see it in this patient where you have access flow being drawn out of the patient and return flow being given back to the patient. So it's a coaxial type of system where you actually only need one pipe to deliver return flow and to also use drainage flow. So a nice nifty little system. The two broad modes of ECMO support or ECLS support, and I hope this projects reasonably well. You can see drainage flow from the venous type of the system and return flow to the arterial side of the system. Again, VA ECMO for heart failure. On the other side, you have a degree of drainage from the venous side of the system and also return to the venous side of the system. So oxygenated blood being delivered back to the venous side of the system, providing just lung support, so just gas exchange, no mechanical support for VV ECMO. It should go without saying that most, or if not all, extracorporeal circuits do require some form of anticoagulation, and how you assess that in terms of ACT, activated clotting time, APTTs, factor 10A levels, is a week's conference in itself. So other than all I'll say about that is to say in our unit we use an activated clotting time mechanism with which to assess how anticoagulated our patients are or not. Very briefly, and lots of you will have seen this this picture before. This is from Bob Bartlett's group in Ann Arbor, Michigan. So this is the very first ECMO patient from the 1970s who was a young male who unfortunately was involved in a motorcycle accident and suffered some severe lung contusions with horrible gas exchange. And you can see the technology and the equipment that they used back then was really nothing like what we use now. This was the oxygenator that they used at the time, which required priming with many, many units of red cells. And this patient fortunately did well, but the technology has evolved quite rapidly through the years. And this is what Leicester use in Glenfield. You can see the oxygenator and the pump head. So really the technology has gotten smaller and smaller and more efficient. In the Mater Hospital in Dublin, we tend to use the Mackay CardioHelp system, and this has the pump head and the oxygenator in one component, if you like. And that sits quite nicely into the Mackay CardioHelp console itself. You can see the pump head oxygenator fits into the back of that console, and it's quite a niche piece of kit in the sense that you can transfer patients between hospitals or to the operating room or from room to room or to the radiology department or so on. It's quite a nice and nifty piece of kit. And that's just demonstrating how it would sit at the bedside with a patient who is cannulated on ECMO. Just to outline briefly, as I touched on earlier, people get quite fixated almost with the pipes and with the drainage and the machines. Really, the ECMO is the machines and the pipes are really only one small or minor part of delivering an ECMO service. Really, it comes down to an entire multidisciplinary team, and the nursing at the bedside really is the primary care for that patient. And I'm very glad to say that the Mater Hospital has been awarded a gold award by the ELSO group, the Extracorporeal Life Support Group, in terms of our accreditation and training in ECMOs, and we're very, very grateful for that. You'll see groups in Stockholm particularly talk about mobile ECMO and trying to minimize sedation, and we find that quite challenging from a nursing burden. It's an ideal world, if you like, and I don't think we're there yet in terms of the COVID-19 group. In the interest of time, I'm going to move on. So what are some of the indications for VV ECMO? So classically severe reversible lung failure that's refractory to conventional supports. And what do I mean by conventional supports? Well, in the COVID-19 era, we're talking about lung protective ventilation. We're particularly talking about proning, and Dr. Waleed's talk covered that really, really nicely. And proning seems to be an intervention that has really found its favor in the current era. It very much works. It's cheap. It is a little bit labor intensive, but it definitely works. It's safe. It is evidence-based. We know from the Claude Guérin group from 2013 that this definitely has an impact in terms of absolute risk reduction of mortality. Likewise, neuromuscular blockade, again, evidence-based in terms of its mortality benefit in severe ARDS. But if you're doing those three things and you're not winning, perhaps you should consider some extracorporeal support. How are we defining ARDS? Because really, VV ECMO in the setting of non-ARDS scenarios doesn't always work out that well. So we're using the new Berlin definitions, and I won't go through them. People can Google them if they haven't heard them before. But particularly, again, in the COVID-19 era, we're talking about that type H phenotype that Luciano Gappnoni and his colleagues, and you've heard about that in the last talk, spoke about. Other conditions outside of ARDS, severe air leaks, so ventilator-induced lung injury, pneumothoraces, and the like, pulmonary contusions in the setting of trauma, and other indications which aren't particularly relevant to COVID. Just to put some numbers on that, and it's useful for people to frame that discussion by using some numbers. The Eolia trial came out with some numbers in the sense of a PF ratio less than 7, or if you like, around 50 millimeters of mercury for greater than 1 hour. A PF ratio of less than about 90 or so for greater than 6 hours, or a respiratory acidosis. And you can see the rest of those numbers there. The RESP score developed out of the Alfred Hospital in Melbourne is a useful tool. As with all scoring systems, it isn't individual specific, it's population based. And you can see it's quite nice and quite easy to fill in, quite accessible. Again, stick it into Google, you'll be able to fill it in quite easily. Very much weighted towards the young population, towards those who are not ventilated for long periods of time, and those who haven't suffered cardiac arrest or have known CNS dysfunction. It very much is weighted against those types of patients, and for good reason. What are some of the contraindications? In reality, there are absolute and relative, but the absolute indications are getting fewer and fewer in recent years. Really what it comes down to, if you think this lung disease is reversible or not, and if there isn't an exit strategy. Bridging ECMO, as it's called, of patients with chronic lung disease to lung transplantation is very much a niche topic and probably outside the bounds of this talk, so I'm not going to touch on it. Other than to say, in terms of the relative contraindications, older patients tend to do poorly. Those who you can't systemically anticoagulate, you're going to have issues with. Those particularly with central nervous system trauma, hemorrhage, or bleeding really anywhere, you're going to get problems as you progress on. The bleeding tendency with ECMO is very real, not just from cannulation sites, but from everywhere. And obviously most devastatingly involved in CNS bleeding. And the acquired von Willebrand's, the thrombocytopenia, the coagulopathy that you get with ECMO is very real. One of our colleagues in the last couple of talks mentioned VA ECMO as a potential in COVID-19. Yes, indeed, the theory is there, particularly that fulminant myocarditis that you see late in the illness, whether it's a stress-induced cardiomyopathy or indeed a myocarditis. It is real. It does happen. Certainly, anecdotal evidence from colleagues in Milan and in London would suggest that it does happen, particularly in the second week. How these patients do, it's really unclear. So the numbers are really low. And if you look at the ELSO registry, just an hour or so ago, I could only see 9 patients who were on a form of VA ECMO for COVID-19. So we do not have data to support or refute whether it's of benefit in this type of patient or not. What about my unit's experience? So we had 2 presumptive patients who we put on ECMO. Only one of those was confirmed to have COVID-19. The second patient was negative, but was treated as presumptive positive at the start. I appreciate single cases aren't helpful, but it does give a nice feel for how we manage this case, particularly because this patient was actually one of the first patients to be positive in terms of its diagnosis in the country. So it was really a sentinel case and a sentinel event for us all in Ireland. This was a relatively young gentleman from my hometown in Cork in the south of Ireland who had a relatively unremarkable background, a pituitary adenoma that was under surveillance and some very mild systemic disease. Of note, he did have some recurrent thromboembolic disease and had a right subclavian vein stent in situ for a number of years. But this was a farmer who was working up to about 5 days before he presented to hospital, was ventilated for COVID-positive pneumonitis for 10 days and referred to us in the matter. He was lymphopenic, he was febrile, he had a high CRP, but he very much met the Berlin criteria for severe ARDS and was failing conventional support. This was his chest radiograph, again 4 quadrant infiltrates as you'll see, and a very grim X-ray and a grim clinical picture. Our retrieval team were deployed. We went to the referring hospital. This patient had uneventful bifemoral ECMO cannulation and was returned to our hospital. Underwent almost 4 weeks of VV ECMO supports, including other supports like dialysis, vasopressors, multiple antimicrobials. He definitely had a prothrombotic state, which other colleagues have referred to, and this is very real, and this is very real in this patient. He clotted off 2 ECMO circuits, a number of dialysis circuits. Lines were difficult with this patient. Unfortunately, we never nailed down the very nature of his prothrombotic event because he was one of the first patients, as I say, to come to us. So it was new to us at the time. But perhaps in questions, other colleagues might want to take that on. As Dr. Waleed mentioned, we have some experience in prone positioning. We did prone this patient on ECMO. He had bifemoral cannulation, so it was pretty easy. The logistics are just a little bit different. You just need a couple of more people to take care of the cannulation sites themselves and the ECMO circuit. Other than that, the actual procedure for proning is undifferent to non-ECMO proning. I'm sorry to say this patient himself almost had no native lung recovery after almost 4 weeks, including a trial of high-dose steroids late in his ECMO run to try and obviate that fibroproliferative phase of ARDS, and ECMO support was withdrawn, and unfortunately he died shortly thereafter. You can't give a talk on ECMO without referring to the CSER trial. This came from Giles Peake and his group in the late 2000s in the context of the H1N1 pandemic. A controversial trial in the sense that it wasn't an ECMO trial per se. It was a transfer to severe acute pulmonary failure center versus not trial. But it did demonstrate at least a proof of concept, if you like, for ECMO as a modality of treatment. And bear in mind, this was 11 years ago at this stage. More recently, the EOLIA trial from Alan Coombs' group has come to fore in 2018, and again, very much a proof of concept trial, just reinforcing that ECMO is at least no worse than conventional mechanical ventilatory support. Despite the, shall we say, less than overwhelming evidence base for the use of ECMO, you can see the number of ECMO centres has exponentially increased since the H1N1 pandemic, and you have almost 14,000 ECMO centres now worldwide, and it's a really a treatment that has very much grown to the fore in recent years. What about outcomes? Well, the Extracorporeal Life Support Organization, as you see, have an ELSO registry, and you can see survival to discharge and survival to ECMO decannulation, somewhere between 60 and 70% worldwide. So not fantastic, but certainly not terrible. And you can bear in mind, if patients didn't have this level of support, their mortality would certainly be approaching 100%. Some special considerations for ECMO in the COVID era. Well, do we have some evidence to support ECMO's use in COVID patients? We have anecdote, we have early prospective evidence. I'm not sure we could say we have robust evidence to support its use. It does seem that the requirement for ECMO in these patients is relatively low. Just talking to colleagues in Italy and talking to colleagues in the UK, it seems unlike the swine flu epidemic, where these patients were profoundly hypoxemic and really didn't respond to any conventional therapies. Important to realize that ECMO, of course, is a very limited resource. You can only do it in a small number of centers, and it has an opportunity cost for other interventions, so other patients who you can't look after because you've taken this patient on in your ECMO center. It definitely is a modality that requires a multidisciplinary team, from intensivists to anaesthetists, surgeons, nursing staff, ECMO specialists, pharmacists, you name it, radiologists. Everyone is really involved in this patient. It's certainly not just a uni-specialty form of support. Other COVID specific issues to realize, I guess, is that COVID tends to disproportionately affect older patients who do not do as well on ECMO support as younger patients. Even take out the ECMO, COVID patients in the elderly tend not to do as well as younger patients, and it's just something to bear in mind. There are infection control issues and personal protective equipment issues. It's hard to look after ECMO patients at the best of times. If you're wearing personal protective equipment for your own safety, it makes that even more challenging. So how do you deliver that service, and should you deliver that service? So that is something which has been to the fore, I guess, in recent weeks. And there's some, not evidence, but certainly some guidance, I guess, particularly from ELSO, who recommend against starting new ECMO centres for the sole purpose of treating these COVID-19 patients. And ELSO are not an organisation to come out with hyperbolic statements, if you like, but they're very much of the opinion that ECMO is not a therapy to be rushed to the front line during a pandemic. Of course, the irony is ECMO came to the fore during the last pandemic in the H1N1 era. However, maybe with a little bit of maturity, we can step back and say that that may not be the most appropriate strategy to take in these days. They advocate transferring patients to a high volume ECMO center if you're going to do it. They again advocate that older patients with multiple comorbidities unlikely to do well either with or without ECMO. So bear that in mind in terms of the resource that you have to use. And again, a rather bold and rather blunt statement to say, consider stopping ECMO after 21 days if you do not see native lung recovery, particularly in a triage scenario or in a surge scenario where you may have other patients who need that resource, who may do better. And that's a difficult thing to try and tease your head around. So there are a number of ECMO centres worldwide, as mentioned. You can see the Dublin centre here, and indeed colleagues in Cairo and Aswan have ELSO registered centres. So it is a real therapy. It can be used, and I'm sure a number of people from around the world are online who work in those ECMO centres. ELSO, despite being an organisation who advocate the use of ECMO, are very much in the do the basics well type of strategy. And you heard in the last talk, the lung protective ventilation, the diuresis or fluid restriction, the prone positioning, the neuromuscular blockade, the high PEEPs, all of those standard severe ARDS types of interventions work. They definitely work in COVID, particularly proning. It just seems again and again that comes through to the fore, that proning does tend to work in these patients, and not just for one prone event, for 3, 4, 5, 6 nights of proning it sometimes is required. So the last couple of slides, I know I'm conscious of time, but I'm nearly there. So who should receive ECMO for COVID disease? So it is a difficult question to ask. You need to prioritize your triaging what is a limited resource. It's not something to take for granted. In our institution, we're definitely advocating the use in younger patients. We don't have a specific age cutoff other than to say in patients above 60, perhaps you should think whether this is a good idea or not. We try and take on patients who have either limited or no major comorbidities. Again and again, and every year that goes past, we tend to push the envelope in terms of taking on patients who are older and sicker. Those who are ventilated for shorter periods of time do better, undoubtedly. Interestingly, what about healthcare workers? So as healthcare workers, we all expose ourselves every day when we go to work to this virus. We are working to try and help our patients. So should we actually receive a degree of priority in terms of assessment if we need ECMO for COVID-related pneumonitis? And I don't have answers to that. It's really just a thought-provoking statement. And of course, as your circumstances change and as your demands and your service change, and if you're into a surge scenario, priorities will change. For those of you working in ECMO centres who have patients, COVID patients on ECMO, please, I just very much plead with you to put these cases into the ELSO registry. It's helpful. The only way we're going to manage to get some data on these types of patients is if they're registered. And this is yesterday evening's data. You saw 227 patients on ECMO with COVID disease registered internationally, and about 30% of those patients have been discharged alive. Interestingly, a little bit less than the total cohort, if you like. There are 2 ongoing trials, the ECMO card and the Euro. So I guess it isn't really a trial, it's more a registry, if you like, to try and get some data on these types of patients. And if you work in an ECMO centre and are interested in either or both of these ideas, then I'd advocate you signing up to them. That's just a screenshot of one particular country's registered data. So I'm going to wrap up. This is just some of the data that I've looked at from the ELSO website. Some of the early, largely e-published data on ECMO and COVID disease. It is very much in the early stages. We're in not in an evidence robust zone. We're very much in the early stages of seeing whether this is a treatment that's suitable for this patient cohort. To summarize, ECMO is a potentially useful support for reversible lung disease and or heart disease in COVID patients. I would very much advocate doing the basics well. So select your patients carefully, try and get the younger patients, try and get them referred early in their illness, try and ensure that the morbidity load is low. Make sure that the lung protective ventilation is done well, and the prone positioning is done well, and repeatedly the neuromuscular blockade, the diuresis and negative fluid balance, all those things very much work. And it may be that ECMO isn't required because it's certainly not the panacea that people think it is. Deployment of ECMO is technically challenging. It's very much a resource intense support. There is a learning curve to delivering it in your institution, and it's hard to try and deliver quality care early in that era. My own opinion is that it's probably too early to assess if ECMO is specifically beneficial in COVID disease. I think the prone positioning and neuromuscular blockade and lung protective ventilation strategies we know they're evidence-based, but I think that's probably the way to go first. Is ECMO better than optimal conventional support in these patients? We don't know, and I await robust, good quality data in the future. With that, I'd like to thank you for your time. I'm sorry if I've gone over time, and thank you again to the organisers. This is a really impressive meeting to be a part of. Thank you.
Thank you so much, Dr. Ian. Actually, time is running, so I just like a question for each of our guest speaker. I'd like to start with Dr. Ian. Actually, I can feel the ECMO as a rescue therapy didn't take the same favorable outcome like MERS-CoV or H1N1. Do you think it is related mainly to the, let us say, epidemiologically or logistics like transmission or infection of the disease, or the new pathophysiological or unclear pathophysiology of the disease itself? It can have the same outcome.
Yeah, a really good question. The short answer is I don't know. This viral disease appears not to be what we thought it was going to be. We thought it was going to be just like H1N1. Patients were going to have hypoxic respiratory failure. We'd look after them for a couple of days and they'd all get better. This is not that disease. The pro-thrombotic state is very real. The pro-inflammatory state is very real. the different phenotypes of how they present is very real. So these are not a homogeneous group of patients. They're a heterogeneous group of patients. And as with every heterogeneous group of patients, one support modality is not going to be an outcome or an intervention that suits all of those. I appreciate that's not a specific answer to your question, but I'm not sure there is a correct answer to your question other than to say these are heterogeneous patients, and I don't know what the right answer is.
Okay. Go back again to Dr. Walid. Actually, I have a couple of questions, all of them related to the, let us say, the relative contraindication of the proning of patient, asking about the, if you have a patient, for example, with pneumothorax, or you have experience with the patient to prone him, the patient with vasopressors, actually, those are the most common questions related to the contraindications. And nutrition. Do you have experience with such conditions in your centers?
Okay, so I will start with the last question and go back from then. So feeding starts the same. The only precautions with feeding is we need to stop the nasogastric tube feeding, aspirate the nasogastric tube before we start proning. And once we prone the patient, we continue feeding. We don't stop feeding while the patient is proned. That's our practice and hospital protocol. And the second point is if you have a pneumothorax, so it is like any regular patient, you need to put an intercostal drain, is mechanically ventilated, and it's not uncommon to have ARDS patient with high airway pressure to develop a pneumothorax. You need to secure that before proning. So if he developed a pneumothorax in prone positioning, which I guess is not the commonest thing, because in theory, when you prone him, you get lower, you get better lung compliance, so you get better airway pressures. That's in theory. We didn't have any pneumothoraces, to my knowledge, during the COVID-19. I may be wrong. Ian is backing me up here. If we had any pneumothoraces in that, so he is pointing to me. Yes, we didn't have any of them. So so the bottom line is, again, you have to outweigh the risk versus the benefit. If the patient had bilateral pneumothoraces and his lungs are really collapsed in presence of intercostal drain, I wouldn't really defer him to proning, because this is an add-on risk. It's my clinical guess. It's not like, again, there is nothing in the literature in that regard. But if it's a simple pneumothorax and you're putting intercostal drain just for sake of his mechanical ventilation settings, either moderate or high, that's fine. You can put an intercostal drain, then clamp the drain while you are proning him. This is what you need to be cautious of while you're proning, because you have to turn him. So either you keep the drains in the downside of the bed, but I believe this would be practically very difficult. So clamp the intercostal drains and open them back after you position him in the prone position. And when he's back to supine, I think will be the same in the vice versa or opposite way. That's it.
Thank you so much, Willie. Muhammad Al-Gindi, actually, also most of the questions related on the modes of mechanical ventilation for the patient with COVID-19. They want to touch roughly which is preferable mode, pressure control, volume control, some theory talk about ABRV, as well as non-invasive ventilation with high frequency before shifting. Do you are preferable to go with non-invasive, or because of visualization, you have to go early with ventilation?
Thank you, Dr. Ahmed. Actually, it's the question of all ages. Actually, first of all, it depends on the pathology. I think everybody in the room share me the opinion of the following. If you have a pathology of having a good lung compliance and your patient is presented by silent hypoxemia, you can go for non-invasive strategy. You can go for high flow nasal and non-invasive. I'm one of the advocates of non-invasive ventilation, actually, because I think that putting the patient on a ventilator carries not so little risk. It's a little bit complicated procedure, and you got a lot of complications starting from putting your patient on the ventilator. But whenever there is a solid indication for mechanical ventilation, it's non-avoidable business. Which mode? I think the high flow nasal and non-invasive CPAP or BiPAP with the proning is a good things to study. I think what he showed me the same opinion with an old study before COVID, but nowadays I think that some of the centers are getting through this. What about the moods, the volume, the pressure, the APRV? I know that you are much interested in this business also, Ahmed. But I think actually the true thing that it doesn't make any difference. Our Egyptian protocol have highlighted this issue by using the volume mood as long as you don't have a very high airway pressure or very high plateau pressure. I don't think it's make a lot of difference. Always we have said and we have taught that I use the mood the most I can use, or the most professional with it, or the most comfortable while using it. Because if you put them in a pressure mood and your patient is coming from bronchospasm and resolving, or the lung parenchyma is having a plug in the airway, so the pressure mood is getting nonsense. While if you put him in a volume mood and you got a volume trauma or bi-trauma, as we all know. I don't advocate one of them. I am equivocal, and I prefer that everyone should use the mood who is experienced on it.
Thank
the APRV,
so yes, continue. Yes.
The APRV is not a big issue. It's we have a lot of advocates nowadays, and maybe a couple of studies done using the APRV in COVID-19. I don't think it will stand a lot because it's having a very much more a little bit hazardous effect, especially if you are not totally sedating your patient, as we all know. If you are sedating him deeply and you are going on new muscular blockade, maybe it's better. Thank you.
Thank you so much. I have two small questions, actually, one for Walid. And if you go through media, actually, nowadays, you can find a very common image. One lady, she's proning while she's awake and mobile and talking on phone, and she's playing with her mobile phone. So it came to ask you, do you have any experience with this proning in awake and conscious patient was what you are saying, heavy hypoxemia?
Okay, perfect. So I'm really happy that you asked this question, because it's discussion all over the world now. There's no enough evidence behind. So every center is thinking, should we start proning our spontaneously breathing patients before the patient crashes? And yes, in our hospital, I've been discussing that with one of the ID consultant who is covering the COVID in the world. We had this discussion. We had an agreement to start thinking about a protocol to put the spontaneously breathing. These patients are not really in ICU. This is pre-ICU setting. So there was like pre-agreement or initial agreement that we may start thinking about a protocol will be between the ICU, because we are proning patient in real life, and the nurses or the CNMs in the ward, because they know the resources, and the medical team in the ward. So we didn't start proning, or we are about to start proning for patients before intubation, but we didn't actually yet. We do the proning for mechanically ventilated patients. And I would like again to take a comment from Ian in that regards, because I'm not present in everyday basis. I don't know the full picture. Ian is the consultant in ICU, and he can give us more in that input.
Thanks, Walid. Yeah, it's interesting, isn't it? So we're used to having our patients sedated and ventilated and proning them, and it's just a whole new paradigm of patients, of asking patients, would you mind going on your front, please? And lots of them quite like being on their front, because you know what, they do it every night at home in bed anyway. Lots of our patients feel better subjectively when they do it. Lots of our patients' oxygenation improves when they do it. I agree with Walid. It's very much geared, I guess, towards a ward level intervention or HDU level intervention. I guess once patients are deteriorating and you know the trajectory of hypoxemia is heading towards probable mechanical ventilation, I guess everyone gets a little bit worried in terms of safety, and everyone wants them on their back in case they need to be intubated. But I'm not sure you're going to have a protocol, because patients who are awake and self-proning aren't going to do what you tell them. If they don't feel, if they're sore, or if their joints are sore, or if they want to eat, or if they want to talk on the phone, they're not going to do it. But if you're at ward level care and you're on some nasal high flow or on some CPAP, and you feel subjectively better and your oxygenation is better, it seems a very low risk intervention to perform.
Thank you so much, Ian. By this, I can close.
Just one
Dr.
question,
Yes.
Dr.
Yes,
Mahdi, please.
Yes,
did the CT before proning is of any significance? For example, the the effect is the radiological findings on the posterior part of the dorsal segments or in the anterior segments. Do you think this make a difference?
It definitely makes a difference, but the question is how precious this one compared to taking the patient down to the CT scanner while he's COVID positive. Yeah, he's intubated and like it's secure airway, but again, the cost benefit. You can get the same result, Prof. Muhammad Ibrahim, with ultrasound scan, because this is really peripheral disease. So if you scan the lungs with an ultrasound at bedside and you find the lung shreds or shredded pleura, this is, I think it's enough. It's peripheral disease. You know that. You can also get a touch of any pleural effusions or pneumonia touching his pleura. That gives you the impression of how severe is the disease. So if you want to get an answer with yes or no, I guess myself, ultrasound will be enough compared to cost and benefit from sending him to the scanner. But if you're sending this patient to the CT scan for any different reason, for example, he's not waking up from his brain insult or something like that, and you want to do a CT chest as an add-on, it's fine. There's some discussions in the moment, like the bottom line, there is no yes or no to that question, but that's my guess anyway. All the evidence now is like is improving day by day, and everyone is
sure.
Thank you so much, Wahid. Actually, I think we have
comparing ultrasound sensitivity and specificity. It's not the worst.
Yeah. Excellent. Thank you. Now time for closing for the session. Dr. Muhammad, Prof. Muhammad Ibrahim, the floor is you.